algorithm that myself and Dr. Sandberg-Lewis came up with back in 2010. It's really Dr. Pimentel's algorithm that he published in 2006. And we just added a few things into it. But why this is really important is either for a doctor or a patient who's dealing with SIBO, you really want to have sort of like a structure in mind of how to deal with this condition, and like sort of what are the phases and what's the process that you need to go through. So let me take you through this. At the top, you have SIBO suspected. So this is going to be if you have symptoms that are making you think you have SIBO. And then you do the breath test. I'm saying this nonchalantly, but I cannot believe how many people don't do the breath test. And we can't diagnose the condition without the breath test. And the reason why is because the symptoms of SIBO are the same symptoms of like around 40 other diseases. And so somebody has bloating, they could have like 40 other diseases. How can you say they have SIBO? You have to do the test and figure it out. Okay, now let's say you've tested and you're positive. So now you're going to move on to treatment. There are 3 antimicrobial type of options, 3 sort of killing options. And then the other one is diet. And so what we do is you pick one of the 3 sort of antimicrobial options. That's elemental diet, herbal antibiotics, and antibiotics. Choose one of them, and then you add diet with it. Now, different doctors like to do it differently. Some of them don't start diet until after the antimicrobials. Some of them start diet before the antimicrobials, and some start them at the same time. We went over diet in an entire masterclass webinar in September with an 50-minute class and like a 4-hour Q&A. So we're not talking about diet today. We're talking about the other part of treatment, the elemental diet, herbal antibiotics, and antibiotics, and then all that comes below. So now you do a treatment, and then when you're done, pretty soon after finishing, you want to get on a prokinetic to make sure you don't backslide. Now, you have to reassess. How did the treatment do? So over on the left-hand side, let's say a person feels better, like really better, like they're better. So I would call that as 90% or greater. Like they feel great. Okay, then you move on to prevention. And you don't have to retest at this point. So why not? Because you have achieved what you're looking for. And sometimes I find, a lot of people want to retest. They sort of want that confirmation. Great. But it's an extra expense, and a lot of people don't want to incur that. And also, a lot of SIBO patients are anxious. That's one of the common symptoms that goes with SIBO. And if they get a test that even has like one part per million that seems like it could be positive, I find they obsess over it and then want to do more and more antimicrobial treatments when they're 90% better. So they get fixated on the test, and that is not healthy or conducive to what we're trying to do. So I often don't retest when someone's really better. And same with most of my colleagues. So we move on to prevention. There's 2 essential things we want to be sure we have covered. Some kind of low-carb diet and a prokinetic, which you already were doing, but you want to be sure you're for sure on it for prevention. And then we very often do meal spacing. And I'll talk about all of this later, but meal spacing, again, could be started earlier, but you for sure just want to make sure you're doing it at this point. Then let's move over to the other side. So let's say you finished your treatment, you're on your prokinetic, but you are not feeling better. You're 80% better. You're 20% better, whatever. You're worse. You're not 90% better. Then we need to do the breath test. This is where we really need the breath test, is when you're not better. Then we need the breath test to find some things out. So what we want to know is, do you still have SIBO or not? Because you do not want to assume that you still have SIBO because you still have symptoms, because there are 40 plus other things that could cause those symptoms, and people often have more than one thing wrong with them at once. I'm sure you all can understand and are nodding in agreement. Many of us have lots of things amiss. So if the test is now negative, so you have symptoms, but your SIBO test is negative, it means the treatment worked, you cleared the SIBO, and it means your symptoms are due to something else, and now you have to look for other conditions. But let's say the test is still positive. That's very common. And what will commonly happen is you've made an improvement, you've brought the gas levels down, or shifted the gas in a positive way so that we can see we're making progress, but it's not finished yet. We're not done yet. So now that's where that big circle goes all the way around. I could have been showing you on my PowerPoint, sorry. I'm over here now. So now the big circle comes up and around like this, the big lines, and now you treat again. This is an extremely important point. Most people with their SIBO, one treatment course, one round of antimicrobial treatment, whichever it is often not enough to get rid of the SIBO, and we need multiple treatments, multiple rounds, treatment rounds. So that is the basic idea. The one thing I didn't cover is that what if you're over here, I don't know if you can see all the way down here, I don't know if that's showing, what if you relapse? You were doing great, but you relapse. It's very common. SIBO is a relapsing condition for the majority. Then you retreat again. Now, a couple other things on this slide I just want to mention are up here. What is this layers of treatment thing? This is just to give you a context of where this algorithm fits in. This is a condition-specific treatment algorithm. So if a person walks in and says, my digestion's bothering me, you don't immediately stamp this algorithm on them. There's a lot of other things you're going to do first. This is for, when you're going to do a test, figure out what a person has, and it's SIBO, and do the treatment. But also, within the context of SIBO itself, there's a couple layers we can treat. We can focus at the symptoms. That's what we used to do before we knew about SIBO. So like you give a laxative for constipation and you try and give something for pain. But if you go one level deeper down into what is causing those symptoms, the SIBO, the bacterial overgrowth, that's what this algorithm is targeting. It's using antimicrobials and a reduced carbohydrate diet to remove the food for the bacteria. So either killing the bacteria or removing their food so that you can then make a difference in the symptoms. And that's an improvement because you're doing sort of one type of treatment, antimicrobial, and now you get all the symptoms. You don't have to treat the constipation separately from this, separately from that. But this algorithm is not addressing the underlying cause. And that's a whole other thing that I'm not going to be talking about today because that is very complex. So what this algorithm is at the middle level. So, I know there are a lot of patients and doctors that get frustrated with, going around in circles on this algorithm, and we all are. And what we really need to do then is go to the underlying cause if you're having a lot of relapse, if we can find it and if we can treat it. Okay, next slide. So I'm going to start with just a broad overview, and then we'll go through antibiotics, herbal antibiotics, and elemental diet. So those are our three main antibacterial treatments. And I just want to make an important point, that is that they're all about equal in effectiveness. With one caveat, which is that antibiotics and herbal antibiotics lower gas on average somewhere around 30 parts per million per treatment course. I mean, that's just an average, but sometimes it's 20, sometimes it's 45. So I'm just going to say 30-ish. That's the common typical pattern. You do a course, and that's what you'll see. Elemental diet, though, can lower gas much more in one treatment course. I've seen it lower gas as much as 100 parts per million or more. Actually, I've seen it go way higher than that, in fact, in one course. So in a way, maybe it is more effective. However, when you look at the studies on the success rates of these three methods, they do statistically come up as about equal. So in 85 to 90% range of effectiveness for eradicating the bacteria and for symptom reduction, which is actually remarkable because most drugs, most pharmaceuticals give somewhere in the 20 to 30 to 40% success. So all three of our treatments are in the around 85 to 90% success. So that's very good news. Okay, so antibiotics. There are three antibiotics that we use for SIBO. Rifaximin, which in the US, the brand is called Xifaxan, neomycin, and metronidazole. And I have the listed for you here. The protocol is that if you just have hydrogen, you would just use rifaximin, a single therapy of rifaximin. But if you additionally have methane, either you have only methane, no hydrogen showing up, just methane, or you have hydrogen and methane together, or if you have constipation, even if you don't have methane, then double therapy is recommended. You add the neomycin or the metronidazole to the rifaximin. So you're doing rifaximin plus neomycin or rifaximin plus metronidazole. And you're taking those like at the same time. So you're swallowing your rifaximin and your neomycin pills, one right after the other at the same time. Now, a typical duration, one treatment course for antibiotics is 2 weeks. But sometimes we'll go a little longer, like to 3 weeks. Sorry about that. I forgot to turn my ringer on. Siobhan, can you hear me?
Yes, I can.
Okay. Do you need me to do anything?
No. Did I text you?
Yes, you texted me. I was like,
nope.
Okay, sorry everyone. Okay, so sometimes we'll go longer if a person has high gas. So what's high gas? This is just how I like to think of it. I think of somewhere in the 0 parts per million all the way up to 45 as mild. 45 to 70 parts per million of gas of either or in combination is moderate. 70 to 100 is high, and 100 plus is severe. That's how I like to classify it anyway. So when someone has high gas, we might go longer because if you're using antibiotics, and we know that on average, they lower gas somewhere around 30 parts per million per treatment course, then you just apply math. So it's like, let's say your gas was 45. Well, then one course of treatment, lowering gas 30 parts per million, should take care of it. But let's say you have 150. Well, then if you lower 30 points, you're still above 100. So to speed the process along, if somebody did not want to do elemental diet, then we would go for 3 weeks, and we can get a little bit more effect. Now, why wouldn't we go longer? Why wouldn't you just keep somebody on for like a month or 6 weeks? Some doctors do. I tried that, and I found I got minimal benefit past 3 weeks. So it was like there was a point of diminishing returns. And I just saw that over and over, so I don't do it. But now there are certainly exceptions to that, exceptions to every pattern. So we can talk in patterns that affect most people, and then there's always exceptions. And I've seen some of those exceptions. I've had patients come to me that were on rifaximin for 4 to 6 weeks, and it really did a great job. But I find I can't get much more out of it past 3 weeks. Now, rifaximin is not your typical antibiotic. I'm sure a lot of you have heard this. This is something really important to know, especially for those who are afraid of antibiotics, or if you feel that antibiotics caused your SIBO or caused your patient's SIBO. So rifaximin is really, really different. It's the standard for SIBO treatment because it's specific to the small intestine. It's not absorbed systemically into the blood, and it has its primary effect in the small intestine and not the large intestine. So it's exactly perfect for the condition, and it's broad spectrum. So that's why everyone wants to use this. It is the right match for the situation. And also it's very safe. So let's go through some of the characteristics. Like I said, it's broad spectrum, so it can kill both gram-negative and positive bacteria. There has been some sensitivity testing done for SIBO where they use an endoscope, go in, culture out the bacteria that are overgrowing in SIBO, and then testing rifaximin against it, and it showed excellent sensitivity for the condition of SIBO. It's not systemically absorbed and mainly works in the small intestine because it's bile-soluble. And so this means it will give less typical antibiotic systemic side effects like urinary tract infections or yeast overgrowth. It prevents the antibiotic resistance that can form against neomycin because it inhibits plasmids, which is the mechanism by which bacteria become resistant to neomycin. It's anti-inflammatory via the NF-kappa B pathway of inflammation via the PXR gene. And so it decreases inflammatory cytokines. This is a really important inflammatory pathway that Dr. Karazian has talked a lot about. He's the first person I learned about it from. And it's amazing that rifaximin turns that pathway off. It is anti-inflammatory. It has been studied and shown not to cause yeast overgrowth. It remarkably increases bifidus and lactobacillus, probiotic species of bacteria, in the large intestine when you take it. That's just crazy. So it doesn't negatively alter the large intestine flora. And because of all this, it's called an antibiotic with eubiotic properties, U being favorable. It's been shown to be safe. It has very low side effects, equal to or less than placebo. Placebo meaning when somebody gets just water or a sugar pill, they're not getting any medicine. What do they claim is wrong with them? It's the same or less when they take rifaximin. So you can see it just goes on and on. And then a few other things. It can decrease LPS and a few other things. Lastly, it is shown to be effective on many repeats of treating. So we can use it again and again without antibiotic resistance. Now, having said all that, I will say that I certainly see people having side effects because the patient type that I see is very sensitive in general as a pattern and will and can react to anything, pretty much anything that comes in their mouth with horrible reactions or mild reactions. So I have seen reactions, but in general, it's extremely well tolerated. The pattern is, it's very well tolerated. And in fact, the pattern that I see is the very sensitive patient tolerates rifaximin better than just about anything. The other thing is that I have since developed to it. So I have seen it where, you give it the second time and it doesn't work. Now, sometimes we have no choice. We try other things. We have to come back to it. So we give it the third time or the fourth time, and then it does work. So I've seen it kind of be on and off like that. And then sometimes in other people, I've seen where it worked once and never again. I would say that's more rare. Now, one other thing I want to say about rifaximin is it's very expensive in the United States and not covered on many insurances. So some options are, there is the company that owns it, Salix. They have a patient assistance program. You can Google that and get the form online that both you and your doctor, or if you're the doctor, you and your patient fill out. There are also coupons you can search for online. I also know that Dr. Mona Morstein likes to use a generic form. I've had quite a lot of trouble using generic forms, but she has found one that she feels is very reliable, and she gets it through Canada Drug Stop. The generic rifaximin does absorb systemically. That is the difference with that versus the branded. So I haven't used it. I can't say that I know about how well it works or how well it's tolerated. I'm just letting you know she likes to use that one. And of course, I love her. She's great. Now, the difference here is that neomycin and metronidazole are typical antibiotics. So neomycin is not absorbed systemically into the blood, but it will it has an effect in the large intestine. So it will kill good bacteria in the large intestine and affect the microbiome, which rifaximin, is positively affecting the microbiome. So neomycin and metronidazole will do the same. Metronidazole, which is also called Flagyl, that is absorbed into the blood, into the body, the circulation. So more side effects, typical antibiotic side effects, could be expected from metronidazole. A point I want to make about neomycin is that many prescribers and patients are afraid of it because it has these warnings about causing deafness or kidney trouble. And that is true with the IV form, but not the oral form. And still, information persists as if it is true with the oral form. But I did a pretty thorough investigation of that, and I could not substantiate that. Also, Dr. Pimentel did a study with rifaximin and neomycin for SIBO, and he had to actually test everyone's hearing just to be sure, and there were no issues. So I feel comfortable with its safety. Now, I can say I have had a few patients, like 5 out of thousands and thousands, get tinnitus. So that could happen, but that is not the same thing as deafness. In the people that I spoke with, it was temporary. Also, neomycin has high resistance rates, so I think we should only use it when you're using it with rifaximin, because then you will be preventing resistance from developing to it. If a person has already used neomycin in the past alone, it might not now be effective. They might already be resistant to it. So that's something you want to think about. Have I had it before? Or doctors ask your patients, have they had it before? Because then you might want to choose metronidazole. Now, with both of these, yeast overgrowth is possible. So when you're using them, you might want to consider using probiotics to prevent yeast overgrowth, or directly antifungals. Prescription options would be like nystatin or diflucan. Options are caprylic acid, undecyclinic acid, uva-ursi, and all of our typical yeast herbal antifungals. All of the SIBO herbal antibiotics are antifungals, and we're coming to those next, so you will see them all. Okay, so moving on to herbal antibiotics. There are two main strategies. Single herbs used together, usually 2 or 3 at a time, or big combination formulas, usually targeting yeast and parasites too. And they really both work equally well. It's just a matter of the patient type of which one you might want to choose. So fewer herbs are better for a more sensitive patient and also those with high gas. Because, you know, so by sensitive patient, I mean they react very easily to herbs, vitamins, you know, any kind of supplement, medicines, and foods. And the thing is that if you only have 2 or 3 herbs, it's much easier to figure out, like if you're using 2 herbs, what's bothering them, because you just take one thing away if they have a reaction and you see if the reaction persists, and then you can quickly and easily resolve a situation. But if you're using a formula with like 20 herbs, you then just have to stop the entire formula. So it's just really a matter of the type of person you're working with, or the type of person you are. And then for those with high gas, because high gas takes multiple rounds, because we can only usually lower gas, I don't know, 30-ish parts per million per treatment course, then you can sort of apply math, times it out, how many courses you're going to need based on your gas. So if you have high gas and you want to do herbal antibiotics, you kind of need to reserve some things. So because I see resistance building very commonly to whatever agent I'm using, particularly with herbs. So it stops working. So then you need to switch to something else. So if somebody's got high gas and you're going to need multiple rounds, I don't want to give a combination formula with 20 herbs, everything I could possibly give at once, because even those usually don't bring gas down any better than the single herbs. And now I've used everything. So that is why I tend to go with the single herb strategy. It's because of the people I work with. However, to give some time to the other side, I have so many colleagues that they just start right out with, they don't see like the hardest type of patient, and they just start right out with these big combination formulas, and they get great results. And so for those, it's going to be the people who are not so sensitive, and the 1/3 of SIBO cases that are thought to not be chronic, so they're a little easier and they resolve easier, and for those with lower gas.
Dr. Seebecker, we do have a question about when you're saying what is high gas. Can you just redefine your version of what high gas means?
Yes, I just went over it. I'll say it again, but remember, you'll have the recording. So 0 to 45 is mild, 45 to 70 is moderate, 70 to 100 is high, and 100 plus is severe. And remember, this is just a thing of math. So it's like if you have 75 and then you think on average a treatment can lower you 30, you take 75 minus 30 and then do it, or divide it, and you see how many rounds might be needed. So that's also sort of, when I say high gas, I really also mean it in terms of applying that math for multiple rounds. Okay, so for the single herbs, there are 4 main herbs we use, and now we sort of have a 5th coming in here. So for hydrogen, what seems to be good against the hydrogen are the berberine herbs, neem, and oregano. Berberine is like a chemical constituent within many herbs. So the herbs that it's in is golden seal root, Oregon grape root, coptis, barberry, philodendron, and yerba mansa. And if you are going to be buying like the actual herb itself, make sure, like with golden seal, that you buy golden seal root and Oregon grape root, but particularly golden seal root, because it's expensive, and so it's sold as golden seal herb as well, where they're using all parts of the plant, and you want to be sure it's just the root. So what I tend to use is I like to use Integrative Therapeutics. They have a product called Berberine Complex. There are many brands that have like berberine complex formulas. Basically, it's 2 or 3 of these berberine containing herbs in one formula. And the dose is anywhere from 3 to 5,000 milligrams a day. That's very high dosing. So 3 to 5 grams a day. And you split that. So typically, this is going to be somewhere, if you're using the 5,000 milligram dose, which is what I tend to use, that's going to be somewhere between 9 to 11 pills of most products, and it might be more, it might be like 14 or 15. So you need to look at the label and see how much berberine is in there and add it all up and then times it out. Now for neem, the typical dose is anywhere from 900 to 1800 milligrams a day, 1800 being the standard. And once again, you split that into 2 or 3 doses. I like to use Ayush Neem Plus. That's what I and all my colleagues use. It's got a little tripholate in there, which might be a mild prokinetic, and it doesn't seem to bother most people. It seems to make most people feel pretty good. On that product, the dosing would be 6 a day, I think, to get that amount. Oregano, if you're using the emulsified form, then it's 200 milligrams a day, split into 2 doses. So 200 milligrams a day of emulsified would be the standard dose. Now, emulsified, what that means is it's not like an oil or a liquid. It's in a powdered, dry tablet form. It's more common to find oregano oil pills where it's like a gel cap with an oil inside. And so what I have found with that, why I prefer to use emulsified, is because the oregano is a bit caustic, at least for some people, on their mucous membranes, on their intestinal mucosa, and can cause stomach pain or burn or just be irritating. And the emulsified seems to lessen that problem. Additionally, we seem to be able to use a lower dose and get the same effect that you would need a higher dose for of the oil in the capsule. So I have the dose listed here for the oil in the capsule. It's somewhere up to around 600 milligrams a day if you're using the oil in the capsule. And so, you would know pretty quick if you try the oregano and it's like, ooh, that burns, that hurts. Then you might want to switch to the emulsified, or it just might not be for you. And as I say that, I don't want to scare anyone, because lots of people find it really well tolerated and their best SIBO treatment herb. Now, the next one is Alimed. This is a product name, and it contains allicin, stabilized allicin. That's the active antibacterial ingredient that's within garlic. And so I would not recommend whole garlic or any like garlic supplement pills that are whole garlic. I really just use this one, Alimed, and that's the brand, I guess. I think it's Alimax International or something. And they have 3 levels of potency. Alimax the lowest, Ali Ultra the middle, and Alimed at the top, the highest potency. And that's what we use. And so we use 2,700 milligrams a day, split into 2 or 3 doses, usually 3. So that's usually 6 Alimed a day. Yeah, and so I guess I just want to allay fears here that we see this product, Alimed product, being well tolerated by even people who cannot eat garlic, or they get their symptoms aggravated, because garlic is highly fermentable. It has FOS and some other fermentable ingredients in it. So the bacteria can go to town, make gas, and make symptoms worse with whole garlic. But we don't see that with Alimed. In fact, Alimed is I would say probably one of the better tolerated herbs out of this whole list. And then the last one is Atrantil, which is a combination product of 3 herbs mint, paudiarco, and concord tree. Paudiarco is also called quebracho bark. And so a lot of people have been hearing about this product. It's been out a couple years and studied for methane and constipation. And the dose is 6 a day. Now, of course, I just want to say anybody can try whatever they want. People might have their favorite herbs, and everyone's always like, asking me, what about this herb? What about that? It's like, sure, I'm just sharing with you what we all use on a daily basis that we know works. So this is our core group of herbs. I've been experimenting with uva ursi for a while, just by itself as a single herb, and I'm liking it, but I'm not ready to fully say what I think. So here are the protocols for this type of situation. The duration is going to be 1 to 2 months. 1 month is the standard. You can go longer, just like we were talking about with the antibiotics. You can go for 6 weeks or maybe 8 if a person has high gas, with the idea that you want to just get a little bit more out of the treatment that you can, because it's going to take a while, round after round. So maybe you can make the round a little longer, and then maybe you would only have to do 2 rounds instead of 3, that sort of a thing. So 6 weeks of herbal antibiotics would be the equivalent to 3 weeks of pharmaceutical antibiotics. And 1 month of herbal antibiotics is equivalent to the 2-week standard course for pharmaceutical antibiotics. So it just takes longer with the herbal antibiotics. Now, I don't like to go past about 2 months of giving the herbs because of the same thing with the antibiotics. I find minimal benefit, sort of a point of diminishing returns after the 2 months. Like, we're really getting good effect, usually up through 6 weeks. But after about 6 weeks, it starts to sort of wane off. In fact, many of the people that I see often start to relapse while they're on the herbs. So it's like they've become totally resistant to the herbs, and now they're just not doing anything, and now they start to relapse. So I myself usually only go to 6 weeks, sometimes 2 months. Again, this is a pattern, and of course I've seen exceptions to this pattern where people are on, in fact, I had a case where someone was on, I can't remember what, one herb for 1.5 years, and it was totally still working. And if she tried to stop it, she would relapse within like 2 days. And that's actually why she came to me, was like for help getting off that herb, making something stick. So of course I've seen exceptions, but I'm just giving you the majority pattern. So what we do is, if a person has hydrogen only, we would use 2 herbs picked from berberine, neem, or oregano. And you use it, you kind of think of it like rifaximin, berberine, neem, or oregano, kind of like rifaximin. So maybe you do berberine and neem, or you do berberine and oregano, or you do neem and oregano. It really doesn't matter. Now, if a person has methane only, or hydrogen and methane, or constipation, then what we do is we add the Alimed, or maybe a Trontil, to one of the herbs above, just like we were doing with neomycin or metronidazole. So like you would do berberine and Alimed, or you would do neem and Alimed, or you might do Alimed and oregano. My personal favorite is berberine and Alimed, but my partner, Dr. Steven Sandberg-Lewis, his favorite is Alimed and neem. It makes no difference, really. So really, whichever way. Now, a Trontil is often used alone, just all by itself, at 6 a day, taken as 2, 2, and 2. And once it helps, if it helps, meaning you really are feeling better, very much better, then the recommendation is to decrease it to a maintenance ongoing dose of anywhere from 1 to 4 a day. I would say most people that I've seen are not on 1 a day on their maintenance, they're on 2 or 3 for their maintenance. And we're starting to experiment with using a Trontil sort of in place of Alimed, like a Trontil plus, say, berberine. But I can't report back on that. Okay, now for the combination, sort of big combination formula, we have a study that was done, multi-center study, where it was wonderful. It was shown that herbal antibiotics are equivalent to pharmaceutical antibiotics for SIBO. So that was wonderful. We finally had the proof. And what they did was they used 2 combination formulas together. So 2 pills of each, 2 times a day. And they either used Metagenics Candibactin AR and BR, so it was 2 pills of each twice a day, or Biotics FC-Cytal and Dysbiocide, 2 of each twice a day. And their results, and they did that for 1 month, and then the results is that it worked, and it was equal, in fact, maybe even a little bit better than pharmaceutical antibiotics. So that's what's been studied. The Candibactin AR and BR, they're not big combination formulas. They're very similar to what I just described as using a few single herbs together, because the Candibactin BR, the BR just stands for berberine. So that's just a combination berberine product. It's just berberine. Has just a few berberine herbs in there, I think. And then the AR, it stands for aromatic oils, and it's like thyme and sage and I can't remember, 1 or 2, lemongrass, I think, maybe one other thing. Oregano, I think, or maybe not. I can't remember. So anyway, it's not a ton of herbs. I have some colleagues that really like to use formulas like GI Microbe X and other really big combinations. So this is where you're going to have probably like 10 or more herbs, maybe 8 or more herbs. And there's going to be herbs in there that are quite specific for parasites and for yeast. So it's just trying to target everything at once. Now, I like my colleagues love using those formulas. They have great success. I have a few things I want to mention that are some problems that you want to consider with those. First off, most of those are missing the allicin, like the Alimed, the allicin. And so if you have methane or constipation, you would want to add that in if you are going to use a big combination formula. Sometimes these formulas, very often, they'll have garlic, and it'll be whole garlic. Now, sometimes that can be okay because it amidst, say, 10 or 20 other items, there's only a tiny bit in there, and so it's not enough to bother a person. But sometimes it is enough to bother a person, and then that's why the formula is not being tolerated very well. So one way or the other, you want to think about that, and then you want to think about maybe you would want to take the big combination, and then you would want to add the Alimed, so you'd be taking 2 things. Also, for people that are doing the Candibactin protocol, the BR, the berberine dose, is very low at the study protocol, which was 4 pills a day. So it's, I think, 250 milligrams. It winds up being like 1,000 milligrams a day. To even get up to 3 grams a day would be 12 pills. That's just the 3 gram, not even the 5 gram. So I think oftentimes where this formula isn't quite effective enough is because people don't have their dosing right on the berberine. So of course, you have the slide with all the dosing. Look at that for whatever products you're going to use. And lastly, antiparasitics, by that I mean black walnut and wormwood, often aggravate SIBO patients. And sometimes it even seems that they stall the progress forward of a SIBO patient. It's not even like there's die-off and you're having to deal with that. It's like you just don't move forward. Now, something that's interesting about this is, to me, this is a pattern I've seen. When I've asked my colleagues, what I have found is those that don't see challenging or chronic patients, those that just see patients that resolve quickly, that are more like the 1/3 of cases that are more quickly resolvable and not chronic, they don't agree with this. They don't have any problems with the antiparasitics. So this kind of goes back to me saying that if you're going to use a big combination formula with all these different antimicrobials in it, it's a good match for somebody who is not a chronic patient. When I've asked my colleagues who do see more challenging cases, those who are more specialists, they all agree with this. So it seems to be about the patient population of whether that is true or not. One other note I will say, the Biotics FC-Cytal and Dysbiocide, I have not seen as much success with that as any of the other things that I have mentioned. So I don't find I see as much success or response. But then sometimes what I've done is I've used it where everything else has been used and didn't work, and then this will work. So I think of it as for the non-typical or the unusual patient. Like most people respond to everything I've just mentioned well. But if they're not, then I think of the FC-Cytal and Dysbiocide. So for me, I don't use this much at all, the FC-Cytal and Dysbiocide. Okay, elemental diet. So elemental diet is a powder or a liquid of pre-digested nutrients that are drunk in place of all meals. And the protocol that we're doing is for 2 weeks, maybe 3 weeks. And so this is the way you do it for SIBO. Elemental diet drinks can be used in other ways, but we would do it to replace all meals for 2 to 3 weeks. The protein is amino acids, fats are oils, and the carbohydrates are glucose usually or maltodextrin. And then there's vitamins, minerals, and some salt for electrolytes. And the concept behind it is to starve the bacteria but still feed the patient, because the idea is, since it's mostly pre-digested, it could absorb into the body very quickly and very high up in the small intestine, and quickly enough also that it doesn't barely get a chance to feed the bacteria. They can't grab onto it and eat it, and so they starve. So the idea is it's killing by a different method than herbal antibiotics and antibiotics. It's killing by starvation. There are lots of different options for formulas. Commercially, what's available over the counter would be, and so that would mean by Googling and getting it on the internet. That's where you usually have to get these from. Vivinex Plus is what the study that Dr. Pimentel did was on. But there are some other options that have extremely similar ingredients and that many of us have used, like Neocate Jr., and that one is flavored. Elecare Jr., Peptamen. Peptamen is actually a semi-elemental formula, which just means that the protein is not all of it is in amino acid form. Some of it is in like tripeptide or peptide form, meaning not fully broken down to amino acids. And the study was done on elemental. I think many people have had success with Peptamen, but if you just want to be absolutely sure and mimic the study, then you would choose an elemental. So Vivinex Plus is not flavored, but the others come flavored. If you choose to get them like that. Another one you can get, but this one has to be gotten from a practitioner, is Integrative Therapeutics Physicians Elemental Diet. That one's also flavored. And then there is my homemade option. So I created a recipe many years ago because elemental diets are pretty expensive. Depending. Now we're seeing some, like the Physicians Elemental Diet that's much cheaper. And I was just looking online. I can't remember what one I was looking at. And it wasn't that bad, but it used to be that they were around $1,000. Now, granted, this is for 2 weeks. It's like all your meals for 2 weeks. So I guess you could think of it that way. But still, it's a lot of money to put forward. So I had a lot of patients that could not afford it. And I came up with a homemade recipe. And that is always available on my website underneath resources handouts. Actually, maybe I will show you. I would like to show you my website so you know where to find these things. But I just want to be sure I don't screw anything up with our webinar here, Siobhan. So let's see. Okay, let me see what I can do here. I know I had a window up. Let me see where I'm at. I might not know. Oh yeah, yes, I think I might be able to do it. Let me see. Okay, hold on a second here. Okay, are you seeing my website homepage?
I'm not. I see the elemental diet options still.
You see the PowerPoint slide?
I do.
Huh. All right. I guess it doesn't work.
I'm going to type in your URL, though, to Allison, to everybody.
Yeah, I was hoping to show you because it's amazing how many people don't seem to know all the things that are available on my website, siboinfo.com. So there's a tab at the top called Resources, and then you can hit from the drop-down menu Handouts, and that's where probably the easiest place to get the recipe for the elemental diet is. There's so many other things there. Okay, so moving on. The protocol for elemental diet is we do it for 2 weeks, and then we retest on day 15. So you've done your elemental diet, and then, on day 14, you drank your elemental diet, and then and so you might have even drunk it, at night, but you still follow a 12-hour fast. So you might have had it at, say, 7 at night, and then the next morning you take your test. So that's how you do it. And you want to get those results as soon as you can. At least this is the way the study, the protocol was done. If you're using a mail-in kit, a lab that does mail-ins, see if the lab will give you overnight results. Some of the labs will let you pay a special fee to get overnight results. The reason you want the results quickly is because the way the original protocol was designed was that you do it for 2 weeks, then you test and see, is it gone? If it's not gone, then you continue on for a 3rd week. So that's why a lot of people will go into a place that has a facility that has a machine and just get the results right then and there, so long as their doctor has authorized that. So if the test was negative at 2 weeks, then you would stop the elemental diet and begin prevention. If the test was positive, then the recommendation is to do 1 more week. But sometimes people are like, I've had enough. I'm not going to do anymore. So fine, you take what you can get. You've lowered the gases, whatever you lowered it in those 2 weeks, and then you move on to another type of treatment, antibiotics or herbal antibiotics. Either way, the recommendation is to stop after 3 weeks. And then at that point, you would retest again to see, okay, are we now clear? Is it now negative after 3 weeks? I do know people that have gone on to do 4 weeks of elemental diet, and that has been successful. It's extremely difficult to do, but some people don't find it difficult to do, believe it or not. And I don't think I've ever told anyone to do it that long, but there are some people that just did it and it worked out for them. So the recommendation from Dr. Pimentel is that you don't do antibiotics or herbal antibiotics concurrently with elemental diet, because the bacteria are thought to be hibernating and they would just be ineffective. They need to be replicating for some of these mechanisms to work on them from the antibiotics. So it would just be like a waste of money. Additionally, the herbal antibiotics have cellulose and plant substances, complex carbohydrates in them that we would not want to be taking in at this time, because we're trying to starve the bacteria. So there are quite a bit of challenges with elemental diet. If you're using an unflavored formula like homemade one or Vivinex, the taste is very bad. Even with a flavored one, the taste can be difficult because the amino acids are bitter. Very bitter. Now, everybody has a different level of taste perception and sensitivity, and some people are like, it's no big deal, I don't see the problem. And other people are traumatized by the taste, like really. So you just would have to see how you are. For the unflavored ones, what used to be done is, like with Vivinex, you could buy flavor packets, and all that was Crystal Light. Crystal Light is like a powdered drink formula that you can mix with water in the US at least, and it's sweetened with aspartame, which is not fermentable. It's not healthy, but for just getting you through this treatment for 2 weeks, maybe it's not the end of the world. So that can be done. It is emotionally difficult because you are not physically eating or chewing. You're not sharing meals with family, friends, and colleagues and such. So you do have to get ready for that and see how you think about how you're going to handle that. But that can be hard. I will say some people actually like it because they feel like it's a break from eating and cooking a lot of times. So some people like it. There is die-off. Now, there can be die-off with any of the treatments, and I'll just talk about that in just a slide or two. But the die-off can be pretty overwhelming with elemental diet because everything could be starving to death, meaning there could be yeast die-off. Maybe there's parasitic die-off. I find the die-off is usually the worst with elemental diet. I think some of that, though, might also be blood sugar challenges, that irregularities that come into people, because there's a lot of these formulas are high carbohydrate. I do have on my homemade recipe one, I have a version that's lower carbohydrate. Some people even choose to modify it and go lower carbohydrate even than what I have. And then that might help. And also, it's just a matter of sometimes sipping it throughout the day will help just to keep things stable. Of course, yeast aggravation is possible due to the simple sugars in elemental diets. They're mostly made of glucose, sometimes maltodextrin. We hear a lot about this, but what I don't see it very commonly, believe it or not. And I see a lot of yeast patients. I guess it's because we either don't do elemental diet or we're doing something to prevent it and handle that. So, it is a real concern you have to think about. I think someone who has active yeast is not the best match. Weight loss is possible. That can be averted by consuming the full and sufficient calories that you are supposed to consume of the elemental diet itself. A lot of people don't want to consume that much of it because they don't like the taste or the texture or whatever, and then they just wind up fasting and losing too much weight. But if you do consume 1,800 to 2,000 calories a day, like you're supposed to on the elemental diet, then you don't lose weight. However, water weight usually will occur. That is expected, and that returns upon eating, and that's usually a few pounds. And we already talked about the blood sugar issues. So I just wanted to show you a before and after test of the elemental diet, just to show you what I mean about the gas it can bring down. So if you take a look, Siobhan, can you see my cursor moving here in the methane?
Yep.
Okay. So if you take a look here in the methane category, you see that by 2 hours, the methane got as high as 95, and then the third hour as high as 134. So, I would consider this severe. For methane, we look at the whole 3 hours. Hydrogen is technically negative, so this is, a methane positive case. This person, she had, her chief complaint was actually body aches, and she had which is not, the most usual typical symptom for SIBO, but she had diarrhea. Now that's interesting because she was a methane case. So that can definitely happen. It's not the standard, but here's a pretty much all methane, and she had diarrhea. And then bloating, flatulence, burping, headaches, and fatigue. So then she did the elemental diet, and take a look at this methane. Zeros all the way down. The highest it got in 2 hours was 4. The highest it got even in the third hour was 5. Now the hydrogen is just a little bit higher right here because hydrogen converts into methane. It takes 4 hydrogens to make 1 methane. So we are seeing a little bit more hydrogen, but it's a negative test. And what happened for her was, she said, her digestion has been wonderful. All her symptoms were gone except fatigue. So that could either be that she felt a little fatigued just from doing the elemental diet and it might go away. In this case, I remember that it was not that. She had fatigue from some other reason. And of course, what causes fatigue? Everything. It's like, what could we think of as causing us fatigue? We could be here all day long. So, that would just have to be worked through with her. So, but it's pretty amazing. This is a typo up here. I wrote hydrogen. I meant to say methane. It came down, 129 parts per million from highest to highest. So that's what's incredible about elemental diet. I'm sure a lot of you have done it who are listening. I'm sure a lot of you haven't, but this is why people are hyped about it, because it can do that. Okay, so die off. Let's talk about that. And by the way, Siobhan, I can see that it's been like 50 minutes and now I'm running over. So just letting you all know that's happening. I'm going to probably talk for another 10 or 15 minutes.
Dr. Seebecker, also, we're having a little bit of a tech issue with some people's internet. I know people are saying that we're gone, but remember that this is the internet. We are having no issues with the vast majority of you. The other thing is, remember, you will be receiving this recording, and then you are also getting transcripts. So I don't know what to say, but carry on, Dr. Seebecker.
Okay, you're covered, basically. Yeah. Okay, so die-off is when you have symptoms that are kind of like feeling like the flu, like fatigue, maybe body aches, like you can't get off the couch, you can't get out of bed, maybe you have swollen glands, or maybe you can't even say what it is, you just feel like you're coming down with something or that sort of thing. And it could also be that your current symptoms worsen, which is just awful. The very thing you're trying to get rid of is now worsening. Particularly, I see bloating as a symptom of die-off. That like really bad bloating will come as die-off. And sometimes you even get new GI symptoms, like maybe you were a constipated patient and now you have diarrhea, or vice versa, or you never had bloating and now you get it, or whatever. So what die-off is about is that as the bacteria die, their cell walls, they break into smaller pieces, and then it just looks like there's more of them. The immune system recognizes that. It's programmed to recognize the cell wall of bacteria, various level, both gram-negative, we know it's the LPS, but there's mechanisms for recognizing the parts of the gram-positive bacteria too. Anyway, the immune system gets upset and thinks there's an infection, and then it creates those symptoms as part of a reaction. Like, if you've got a flu, you know that you're fighting a virus. Well, it's the same sort of thing. So it commonly occurs on day 2 to 5 and usually lasts 1 to 3 days, but it can start right away, day 1, dose 1, and last the whole entire course, especially for herbal antibiotics. And that's just awful. So you might be feeling worse the whole month of your herbal antibiotic treatment. Where this is especially true is when someone has higher levels of gas, because there's just more bacteria to kill. So at first there's a lot more dying, and you get a worse die-off, and it lasts until you sort of get that level down and there's less there to trigger the immune system. And also the other place that happens is with yeast overgrowth. So yeast die-off is worse even than bacterial die-off, because the immune system actually recognizes 171 antigens of Candida. So it's more upset. It gets even more upset when there's Candida there, or yeast. So this is really a sign when somebody has if you put them on herbal antibiotics, or you're on herbal antibiotics and you have really bad die-off, that is often a clinical sign that you have yeast. Not always, but it really, you should be thinking about that. So here's some things you can do. The obvious thing to do is decrease the dose or even stop it till the reaction calms. And it usually takes 1 to 3 days for the reaction to calm down. So, how much would you decrease it? You could decrease it a half. You could decrease it 3/4. There's no set protocol. The idea is you just either decrease or stop, get yourself feeling good again, and then titrate back up slowly. So let's say you drop down to a half dose and after a day you were feeling better. Okay, then just add maybe one more pill the next day and see how you do. Okay, another pill. You just titrate up slowly. Basically, you're just doing it to your own tolerance. So if you then get a bad die-off reaction, you go back down, wait till it calms, hold at that level for a few more days, and try again titrating up. And that takes time. So yeast dosing, this is very, very common. What we do when we're trying to use antifungals to kill yeast, you do a slow titration up. It could take 1 month. It could take 6 weeks to get to the full dose that you need to get to because of the die-off with yeast. Okay, now you could also do anti-inflammatories like high-dose vitamin C, high-dose fish oil, high-dose turmeric, and resveratrol. Those are all good anti-inflammatories. You could also do ibuprofen. Lots of Lyme specialists recommend ibuprofen. A lot of Lyme specialists also like Alka-Seltzer Gold. I have that lower down. Epsom salt baths can help. Of course, it's not as strong of a helper, but it does help a lot of people. And charcoal. Charcoal is an adsorbent, so it absorbs what's in the intestines. Clays do that as well. Clays can be a little bit more bothersome to a SIBO patient, which is why I didn't put them on here. I would prefer to use charcoal as my adsorbent recommendation for die-off. Charcoal's used like if there's swallowing, like poison swallowing, they use it. It absorbs what's in the stomach, in the ER. And then, and the dosing on charcoal is 2 pills every 2 hours. That would be the max. You could go up to 3 pills. So I guess the max would be 3 pills every 2 hours. But charcoal, one thing about charcoal is that it absorbs everything. So you want to try and take it away from the medicines that you're taking, because it will absorb them, and it will absorb nutrients from your food as well. So you have to be careful with how you're dosing it. Now, for a day or two, with die-off and you're just trying to feel better, it's not the biggest deal, but be careful with important medicines. Don't take that near that. Now, the other thing you could do, I kind of mentioned this before, is you could switch to rifaximin or antibiotics, because rifaximin is just so well tolerated in general by sensitive people. And if you switch to an antibiotic, they are not killing yeast. So then you're taking away the yeast die-off component. also. And lastly, if you expect die-off, just start with low dose and titrate up slowly. So if you're a person who knows you always get die-off, or or you're really worried about it, start low and titrate up over, in that case, if maybe you won't get it, but it might take you 4 days or 5 days to titrate up, and that might be peace of mind. Okay, now I want to just focus on methane and hydrogen sulfide. So this is a list. I think this slide is like gold for both practitioners and patients this is a list of what you can use if you have methane. Elemental diet, rifaximin and neomycin, rifaximin and metronidazole, allicin, so that's Alimed. The product name is Alimed, plus any herbal antibiotic. So that's like allicin plus berberine or allicin plus neem. Or you could use it with rifaximin. If you can't use neomycin or metronidazole for some reason, you could use the allicin. Atrantil, you could use that alone or in combo. Statins, this is something Dr. Pimentel's been using for years. He used to use Pravastatin, but he's been researching a new option that is, better. He found Pravastatin wasn't giving him the results that he wanted, and wasn't working well enough, so he created this new version of lovastatin. It's lovastatin. It's like SYN 010. Still in research, not out yet, but the idea is it stays in the intestines and only works in the intestines, so it's not going to have the systemic effects of a statin, hopefully. So good results he's seeing on that. But in the meantime, you could try Pravastatin if you wanted. You just have to know that all the side effects of statins could come with that. And then down at the bottom, I've got some colleagues that are thinking bismuth might help with methane. And Alinea, there's some research. It's a drug name is natazoxanide. It's called Alinea. I find Alinea can be hard on some people, so sometimes I only do it for a short time. That's why I've got 3 to 5 days here. Then there are other people that have no issue with it at all, and they can take a full, 2 weeks or whatever. That's an option. I've got those in italics because I'm not so sure about those. The others we know about for sure. Hydrogen sulfide. Bismuth is probably one of our best bets. There was a study done where they used about 2,000 milligrams a day in split dosing. Split dosing means just divide that up into 2 or 3 or even 4 doses throughout the day. And they in the study, they used it for about a week. But when I did that with people in various forms of bismuth, it would work, but they would immediately relapse. And I could just tell it wasn't long enough. So I think you'd want to do it for at least 2 weeks, if not a month. And how you can get bismuth is you can get it from a compounding pharmacy. They can do usually subnitrate. You just have to talk to your local pharmacy and ask them to do it. Here in Portland, one of our compounding pharmacy chains we sort of have, conglomerations, has it ready to go. I've spoken with them, so we have that ready. But for over-the-counter, OTC stands for over-the-counter. Thorne has a citrate, a bismuth citrate, in their PeptiGuard product. You would need 8 a day of those to be able to get to that 2,000 milligrams a day. That one also has berberine, licorice, and aloe. Now, licorice and aloe are mucopolysaccharide, mucilaginous herbs that can be very easily fermentable by bacteria. And so sometimes they bother people. They might aggravate bloating, but then other times they don't. And I think it just depends on how much is in the product. So certainly worth a go. There's an over-the-counter subnitrate from Priority One. That's the new product that was formulated by Dr. Paul Anderson. It's called Biofilm Phase 2 Advanced. You would need 10 a day of that product to get the 2,000 milligrams of bismuth. And that one also has alpha-lipoic acid and black cumin. Or you could just use the subsalicylate form that is known as Pepto-Bismol, and there are generics of that. Other companies make it besides Pepto-Bismol. One thing to think about there is Pepto-Bismol is a liquid that has usually sugar alcohol sweeteners, which might aggravate symptoms. So, and chewable tablets will have the same, but you can find some in actual swallowable pills, and then they won't have those sugars. Something else I've used with success is high-dose oregano, and I use the Biotics ADP version. That's that emulsified oregano. And the dosing is, I think, an old chiropractic parasite technique. So it's 5 tablets 3 times a day for 10 days, and then you drop down to 3 tablets 3 times a day for the next 20 days, giving you a month of treatment, I have seen that help. Hydrogen sulfide. Not everybody. Nothing we ever give works on everybody. That's how it goes. But it works great on this person, and the next person it doesn't, and that's how everything is. What we used to do for hydrogen sulfide was we would just treat it the same way we would do hydrogen or methane type SIBO. So if they had methane type, we would use the double antibiotics or that sort of thing. But I did not find very good success with that. And also, Alimed, allicin is a sulfur donor, so I don't think that's the best choice, although I have actually had hydrogen sulfide patients that did respond and have good treatment from Alimed, because we ran out of everything else, and they actually tried it themselves, and it worked. So go figure. Another thing you might want to do is a reduced sulfur diet, and just be cautious with supplements that are sulfur donors, like allicin and garlic. Berberine sulfate. Berberine sometimes comes in a form with a sulfate on it. Epsom salt has sulfate. That can aggravate some people with hydrogen sulfide, and there's a few others down here. Okay, what to expect from treatment? Basically, it could just be anything. You might feel better quickly or during or soon after. You might feel worse. That could be a die-off, or it could be like an allergic reaction. You could feel nothing, like didn't really do anything, or maybe just a slight improvement. After treatment, you could be all the way better. You could be partially better. You could be partially better and then get better over time. Like as it goes out from the treatment, you're feeling better and better. That's a very good sign. And it's not that common, I'll say, in the people I see, but it's good when that happens. You could feel worse. Your symptoms could be worse. Your breath test could be worse. I say, you keep treating it unless your symptoms are better. If your symptoms are better, I don't keep treating. Okay, prevention and prokinetics. So we're done now with the main treatment part. So now I want to just talk about the prevention part. So here's what you would want to think about doing. Well, first off, let me just say, relapse is expected in the majority, meaning 2/3 of cases. That's what the study shows. About 2/3 of SIBO cases are chronic. But these preventative treatments can prolong the remission periods. And I think over time, they keep extending the remission periods longer, which is good. So we want to do prokinetics, some kind of a SIBO diet, a low-carb diet, and meal spacing. So meal spacing is leaving 4 hours, if you can, between your meals and a 12-hour fast overnight. And then additionally, you could consider things like hydrochloric acid or enzymes, because they kill bacteria, visceral manipulation, or other body work. But I particularly, for the case of SIBO, like visceral manipulation. I think that can be very helpful for prevention phase. And then general stress reduction, because it allows the protective mechanisms to do their job. So we have 6 main prokinetics we consider for SIBO. And the way we dose them is at night before bed, and that is meant to stimulate the migrating motor complex overnight. So 3 pharmaceuticals are low-dose erythromycin, low-dose prucalopride, and low-dose naltrexone, which is called LDN for short. And I have the dosages for you here. And then herbally, it would be iberogast, Modal Pro, or just ginger root, straight ginger. One little note I want to make is that erythromycin is an antibiotic, but when we use it in a low dose, it doesn't have that effect, and it works instead as a prokinetic. And so that is confusing to a lot of people, because they'll say, well, now I'm on my antibiotic. And so, yes, it is an antibiotic, but it really isn't working like that at this low dose. So it's here used as a prokinetic. It's one of the main prokinetics used for gastroparesis, or slow stomach emptying.
Dr. Seebecker, can you explain visceral manipulation for a second?
Mm-hmm.
It's a little bit back, but
yes, it's a type of body work. I wouldn't call it massage. It's almost like a physical therapy, or a type of body work that is meant to actually manipulate the organs or the viscera inside the abdominal cavity, as well as other tissue structures that they're connected to. And the way you can find a practitioner is if you go to the Upledger Institute site, or you can also go to the Barrel Institute, but Upledger works just as well. And they have like a find a practitioner button. I think it's on the top. And then it goes to a different site. And then you can put where you are, your location, and search for people who have been trained in it near you. It's one of the reasons I love it, because people all around the world can usually find a practitioner. And it helps, I think it helps with motility, and I think it can help with structural issues as well. So, and so often we have both of those problems as an underlying cause, one or the other, in SIBO. So I don't know, I've just seen it work very well for a lot of people. So that's what I like to recommend as one of the preventions. Okay, how to choose a prokinetic out of all those options. If you really need to be sure, if you really want to be sure the effect is going to be there and you're not going to relapse, then I would choose prucalopride or erythromycin. I think they're the strongest. So let's just go through them briefly. So prucalopride is also called Resilor in the United States. That's its like brand name, or Resitran in Canada. I don't know about other countries. So choose that when you really need effectiveness. Like, you've been through the ringer or whatever, you don't want to gamble. That doesn't mean you won't relapse. It just means it's the strongest at helping prolong the remission period. Also, if you were IBS check positive, I guess now I shouldn't be calling it that anymore because there are other companies offering it. So it's the vinculin and CDTB antibody test. So if that's positive, then we know your underlying cause is deficiency of the migrating motor complex, or at least that is present. And so you probably really want a strong prokinetic. If a person has constipation, it's a good match, but it doesn't mean that you shouldn't use it with somebody who has diarrhea. It's just an especially good match if somebody has constipation. For low-dose erythromycin, again, if you need effectiveness, this would be like, oh, maybe the person does have diarrhea and you're trying to choose between the two. You might choose the erythromycin versus the prucalopride. Also, as I mentioned, this is used in patients that have gastroparesis, so it would be a good match for somebody that has that. LDN is good when you have a lot of inflammation or another condition causing a lot of inflammation, like fibromyalgia or something like that, or osteoarthritis, rheumatoid arthritis. It's also good in cases of autoimmunity. It's used to help balance the immune system. So it also might be good for somebody that's positive with IBS CHEK or the vinculin CDTB antibodies. It's also helpful for depression. So if somebody has that, you might choose this one. Iberogast, you would choose that if you want a natural prokinetic. You don't want a pharmaceutical. And it's very good at broad symptom relief. So if you also want to get a sort of a broad symptom relief, especially it's good for nausea. So you might want to choose it for someone with that. It's liquid and it does have a taste. So like that could be a reason you're choosing it or not choosing it. Like you might choose it for a child or not choose it for somebody who doesn't want to mess with the liquid. Modal Pro, again, if you want something natural, this is a better match for somebody who has constipation because it can stimulate large intestine motility. This one in particular has an ingredient in there that is meant to do that. So it's better for constipation. And it has 5-HTP in it, which can help with depression. So it might be a good match for somebody like that. And the ginger in it has ginger in it. The ginger can sometimes aggravate acid reflux or just cause sort of ginger burn on its own. So I wouldn't recommend it for somebody that has acid reflux. Now, I will say that some people take it, they get that ginger burn and they don't care. They just drink a bunch of water because they really like the Modal Pro. They think it works well for them. So these are just considerations. And ginger, same sort of thing. If you want something natural, ginger is a classic remedy for nausea and gastroparesis, been studied for it. So good to use in patients that have that. And again, not with somebody that has acid reflux. When to start them? You want to start them very soon after you finish whatever antimicrobial treatment. The good thing about this is that you would prevent someone who might just relapse right away. But the bad thing about this is you've just now started a new medicine, so it's a little hard to assess the effect of the treatment when you're just starting something new, because what if somebody now starts reacting to that? They might have been like, oh, I did great, but now I feel awful, and you guys aren't together piecing it together that they're reacting to their prokinetic. It can be hard to do that. So because of that, you might want to wait just a few days, like 3 days or maybe 5 days. I don't know, just a few days. So you get a sense of what the treatment did before you start a new medicine. And what's good about that is then it gives you a chance to retest. So, you stop the treatment, maybe you retest on day 3, and that night you start your prokinetics, something like that. The only problem is, what if somebody relapsed right away? Then that would be a bummer. So, and how are you supposed to know that ahead? That's why there's just options here. Nothing is the set right way to do it. But do plan ahead with your prokinetic, because as the doctor, you want to be sure the patient has the prokinetic, what they're going to take ready to go, or the prescription, whatever, because they need to start it very soon after, like right after they finish their antimicrobial. So you don't want them waiting on coming back to you. What if something happens? They have to cancel. Same thing with you as the patient. Make sure you get that from your doctor. And if they're unwilling, then you procure for yourself one of the over-counter natural ones. How long do we do them? A minimum of 3 to 6 months, somewhere within that time frame, and then you remove it and see how it goes. Certainly that's going to be appropriate for the 1/3 of cases that are not chronic, or maybe that had a short duration of SIBO. It's a little tricky to decide that a short duration of SIBO might mean they're not going to be chronic. But anyway, but most people, the majority who are chronic, will need prokinetics ongoing, or certainly long-term. So Dr. Weinstock says if they've had SIBO more than 5 years, they're likely to just need it ongoing. And certainly if whenever they've stopped their prokinetic before they've relapsed, then you should just continue it. But of course, you can do a trial removal at any time, Like you're not forced to be on this thing. Stop it and see what happens. The only risk is that you would relapse. I do recommend that when you're stopping it, you cut down slowly, you titrate down slowly to catch a possible relapse before it really gets entrenched. Okay, so some basic points here. Prokinetics don't clear SIBO. They're not a treatment for SIBO. So, and also don't expect symptom relief in most, unless you're using them at a little bit of a higher dose, or also in the day, like around mealtime. Because we can use them that way to help with symptoms. But if we're just using a low dose at night, we're not trying to treat symptoms, and we're not trying to clear the SIBO. So the takeaway from this is, like, for the patients, don't stop the prokinetic because you can't feel it working, because you're really not supposed to feel it unless it's being used in the day or at higher doses for symptomatic relief. It's also okay to keep doing them during multiple courses, but it's not necessary. Everybody asks this question, so whenever I give a talk. So the important time to be on them is between courses to keep the gains you've made. So you can stop them during the treatment, so you can kind of save some money and you're not doing too many things. But like, for instance, LDN is usually titrated up. So in that case, just maybe stay on it, because you don't want to now have to titrate up again as soon as you stop your antimicrobial. And it is okay to retest SIBO while you're doing prokinetics, but just stop for 2 nights before, just so it's not interfering. And I know I've made this point before, but I really want to share my experience here. The natural ones in LDN are not strong enough for many people. They are strong enough for some, but for many, they're not. So if you want to be sure, then use erythromycin or prucalopride. I have so many people and doctors coming to me saying, like, my patient keeps relapsing and they're on Modopro. And it's like, well, have you tried any other prokinetics? And they'll say, well, no, so you have to try other ones. Or maybe they're like, well, I tried Modopro, Iberogast, and Ginger, and they're constantly relapsing. It's like, well, use prucalopride. So these are the options. And also you can combine them because the mechanisms of action are different. And I do that in a lot of challenging cases. Prokinetics can be used with diarrhea patients. Prokinetics are not actually laxatives, especially the low doses we use. They are meant to stimulate the migrating motor complex in the small intestine. They are not meant to stimulate a bowel movement in the large intestine, from the large intestine. And remember that most with, or maybe you don't know, most with SIBO of the diarrhea type have diarrhea within the large intestine, coming from the large intestine, but they have deficient or slow motility in the small intestine, deficient MMC. So the small intestine has slow motility while the large intestine has fast motility. So, they got the SIBO from the slow small intestine motility, and this prokinetic is meant to help the small intestine motility. But any medicine given to anybody could cause diarrhea. It's like probably the most common side effect of any medicine. It's probably on like every leaflet of everything. So if by chance you got diarrhea, either lower the dose and see if that does the job, or switch to a different one and see how that does. And also, on the converse side, please know that that laxatives are not prokinetics. They don't stimulate the migrating motor complex. So like magnesium, vitamin C, Miralax, Linzess, Amitiza, all these, they are not stimulating the migrating motor complex. So they are not doing the prevention that we need. So don't think to yourself, well, I'm on my magnesium, so I don't need a prokinetic. No, those are two totally different things targeting different organs. Okay, I'm at the very end now. I went on so long, but we're almost done. Hopefully you're finding it helpful. So here's the summary of it. Okay, thanks, Siobhan. I know it's a long time to listen. Okay, so the 4 treatments are antibiotics, herbal antibiotics, and elemental diet. You pick one of those 3, and then you combine it with diet in various configurations. The 3 preventions are prokinetic, diet, and meal spacing. You do those all together. And for chronic or like really like incurable cases where we can't even really get a remission period, I just wanted to mention we'll do cyclic or even ongoing treatment. And by treatment, I mean, of course, diet, but also the antimicrobials. We usually find some sort of pattern of a cycle that we might need to do. Now, this is one of the last things I really want to hammer home is how important the appointment schedule is if you want to successfully treat the SIBO and get it eradicated or in remission. The timing really matters. You don't want big breaks between what you're doing, particularly like, let's say you got your first test, it's positive, you're trying to work that through. Know that most people are going to need multiple rounds. You don't want a lot of time going between these multiple rounds. You don't want time going between starting a prokinetic, finishing your antimicrobial and starting a prokinetic. That is just no good. Like, basically, it's like, you know, if we could put someone on antimicrobial for, I don't know how long it would take for each case. Let's just say on average, it might take 2 months straight or 3 months straight of an antimicrobial. We would do it, but we find that it loses its effect. And so we have to stop and use something else. And so don't leave good big breaks between that because then people just regress. So here would be a recommendation for the treatment schedule. Let's say the first appointment, you know, you're ordering the test and you're giving the symptomatic relief suggestions handout. Now, I wanted to show you, I have that up on my screen. I'll see if I can get to it, Siobhan, later to show you. I have the symptomatic relief suggestions handout and supplement checklist handout. You can always find that on my website under resources handouts. Anyway, you want to give those because when you take the test, it's a challenge test and it could flare symptoms. And so you want to have some ideas of what you can do if the test makes you feel bad. And then a lot of practitioners are giving diet at the very first appointment and others aren't. Now, at the second appointment, you're reviewing the test results. Or let's say you already had your test done and you're going by someone else, you're going into a consultant or something. Now we're reviewing the results of the test. If it's positive, a bunch of things need to happen. You need to give the antimicrobial treatment, antibiotic, herbal antibiotic, elemental diet. You need to give the diet because even if you are not going to do it till after, they're going to need to start it after. You have to give the prokinetic or the prescription for it because they're going to start it right after the antimicrobial. And you need to give a retest kit or a retest order because that's going to be taken right after the antimicrobial treatment. So that's a lot. You got to get done in that second appointment. And then the patient has to do a lot. After that, they got to do the antimicrobial treatment, complete it, start the prokinetic, take their retest, and start a diet. If they were already on a diet, then they're probably doing some customization at this point. Then you meet to go over the retest results and just see how the treatment went. And that's what I've got bolded. You want to do that within 2 weeks. The timing really does matter. Yes, you could go out longer, but I'm just telling you, you want to try and get this done in a timely manner. Now, here's where if a person is symptomatically 90% better, you just move on to prevention and you'd probably follow up in 3 months at that point, or if the person relapses. And if they're not 90% better and their breath test is still positive, then you're going to give another treatment. You're just going to continue on in the same vein, you know, and then you're going to have to retest and you'll have to see how the prokinetic goes. But you're just working through to try and get that initial test negative. If the breath test was negative, then it's time to look for another diagnosis. If that's out of the practitioner's scope, then they need to refer. And lastly, if somebody relapses, then you retreat. And if there's no relapse within 3 to 6 months, then you remove the prokinetic. So hopefully that gives a sense of it. I know doctors that have actually rearranged their practice, the way they schedule and practice, to handle SIBO patients, because timing matters. And it was a big factor in why they weren't getting success, is because they couldn't get the patient back in for an appointment quick enough or soon enough. And they rearranged things, and now they're having great success all of a sudden. So this is a whole other important layer and part of SIBO treatment. Okay, last slides. This is my key points for success. And we've talked about most of these. And I've got my little gold bars here, because this is sort of like the summary of like all the things that I and my colleagues have learned after all these years of treating it. First off is to be sure to test. You want a 3-hour lactulose breath test that tests for both hydrogen and methane. Make sure you test, because otherwise we don't even know if we're treating SIBO. And plus we need the information about which gases are there and how high. Successive treatment rounds are often needed. That's very, very common. It's the standard. Methane and hydrogen sulfide and constipation cases are harder to treat. Just know that at going in. Different treatment is needed for methane, hydrogen sulfide, and constipation cases, and we went over those. Die-off is common. It's a good idea to be forewarned so that you don't think something horrible is happening to you. Know that die-off is common. Vary the treatment method as needed between antibiotics, herbal antibiotics, and elemental diet. Often only one of these approaches will work for any given patient, and it's different patient to patient. And it just, no rhyme or reason to it. It's just, you try a bunch of herbals and it's just not doing anything. They're not better. The test isn't even moving. And then you switch over to antibiotics and bam, all of a sudden you get movement. And it's like that with every single one. Sometimes the only thing that works is the herbals, and sometimes the only thing that works is the elemental diet. So this is a really important point, especially for practitioners who maybe don't have a full prescribing license. They often don't want to tell a patient to take something that they're not giving them. And that can be a real problem for getting the best result for the patient. If it's time to take rifaximin, or if rifaximin might be the best suited for them, ask them to get it from their prescribing doctor. They can still follow up with that practitioner who is managing their case.
Dr.
So
Siegel,
yeah.
Nice quick question. Are there long-term ramifications for doing the herbals? Like, people are asking, can you be on herbals long-term?
Yeah, you can. Lots of people do that, but it's not optimal, because we don't want to, and we shouldn't be going through life on a constant, continual antimicrobial. However, I did just mention in really more recalcitrant, incurable cases, sometimes we have to do that. So we only go to that when we have to last. So make sure you're in that situation that, like a systemic sclerosis patient who, they are constantly, their disease is giving them SIBO constantly, and it's a constant battle, something like that. But the ramifications would really be on the microbiome. And it depends. Like berberine does kill commensal and probiotic bacteria in our large intestine. I know allicin is reported not to. I don't know about the others. So that's the concern. The concern is that, or are any of the herbs harsh on you, or are they having other, herbs are used for all kinds of things. So are they having other effects that might not be beneficial to you, that are aggravating? So I don't know of anything like fatal or, it's not like I've not heard of them causing diseases, but I think we're really concerned more about the microbiome. And I don't think anybody likes the idea of someone always having to be on an antimicrobial. Yeah. I mean, we talked about how some people do get benefit from being on herbs like for 3 months. And if that's true, go ahead and do that. I mean, especially as a way to get that SIBO treated. While we're in a treatment phase, we do what we need to do. And then we try to stop that and move into a prevention phase where we are not doing that. And we're doing a prokinetic and diet. And now you're not having to treat with an antimicrobial.
Thank you.
Okay, so yeah, I just want to harp on this for 1 second more, which is that this is a really common way people like come to me where they've had failure in their case, is that either it's a patient that the practitioner wasn't willing to try the other methods of treatment for philosophical or maybe whatever prescribing reasons, or it's a doctor who is just only wants to use herbs or something, and isn't willing to try the others. And they're like, why can't I get my patient better? And I'm like, well, you have these other tools, use these other tools. And conversely, there might be MDs who will think herbs and natural things don't work and will only use antibiotics. I've seen it every which way, and it's not helpful. Thank God, we have all of these tools in our toolkit. And if you're not having success, switch. Okay, number 7, retest to assess results. So important. This is if you're not feeling better. So important. Otherwise, your SIBO could be gone. How do we know? The symptoms are the same as 40 other diseases. So just know that relapse is common and expected in the 2/3 of cases. So we have to be prepared, and we have to, of course, do our best to find the underlying cause, which is hard. And number 9, both prokinetic and diet for the prevention of relapse. Prokinetic is left out of so many people's treatment plans. So is diet the whole way through, in fact. But it's imperative to be on a prokinetic when you finish your treatment course, unless you or the doctor has some suspicion that you are a really easy case and will not be heading towards relapse. Or if you don't mind chancing it and just seeing, and then if you relapse, then you have to treat again. And then you go on your prokinetic. But it's probably the key missing element in most people's whole treatment strategy is the prokinetic. And lastly, diet must be customized to the individual through experimentation. Sometimes you get lucky and the SIBO diet exactly matches and fits you and it's just perfect. But for the most part, whatever, a person goes on a SIBO diet and then some of the items in that diet are still triggering them and have to be fiddled with. And conversely, there will be some things that are off the diet they've taken out that they don't need to, that they can put back in and won't bother them. So of course we had a whole separate masterclass about diet. So that's it. I'm done. I went way over, and thank you for listening.
It was fantastic. It was fantastic. And I always learn something new from you, even though I've heard the presentation on more than one occasion. And I love your approach about how you, Dr. Seebecker, when you go to conferences and you've heard people give presentations time and time again, you always learn something new. I so appreciate that about you.
Yeah, you and I have talked about this. Usually when somebody says, I didn't learn anything new, it's just about their receptivity. Maybe they have brain fog, or they're really tired, or they're distracted or stressed, or, they're just not open and ready to learn. But I was telling you, Siobhan, that I've gone to lectures by my students where I taught them, and then I learned stuff. You can always learn something from somebody, always.
Always.
Yeah.
So here you guys are. Thank you so much for being here. Don't worry, it's not over. I know we have a huge Q&A to do.